some of the challenges and opportunities related to the use of neural stem cells to repair and regenerate the chronically injured spinal cord. And David Kaplan and Charles Tator have commented on a number of these issues, and I'm going to present this from a slightly different perspective. I wanted to acknowledge all of the team members who are here. This is what we do with these photographs, and we update our acknowledgement slide, so we'll have a new slide to show next year. So I like to think about things in the laboratory from a clinical perspective, and the reality is that this is what spinal cord injury looks like. And it used to be that about 50% of injuries were in the cervical cord. It's now around 70% of injuries in the cervical cord. And this is a typical example. This is a gentleman with a diving-related spinal cord injury. He's got a dislocation of the spine of C4-5. He has a complete motor and sensory deficit. And this kind of a lesion is very different from a thoracic lesion. It's different in terms of the clinical presentation. It's different in terms of the readouts. It's different if you want to operate on somebody like this. And it's different if you want to apply approaches such as neural stem cells. And so one of the barriers to translational application has been the lack of models of cervical spinal cord injury. So I wanted to talk a little bit about the cervical injury, and then I wanted to talk about the chronic lesion, some of the opportunities and limitations with neural stem cells, and what I think is actually going to be required, namely combinatorial strategies to try to move this forward. The incidence of spinal cord injury is difficult to pin down, and this is because there are many different terms that are used for spinal cord injury. So we can think of a traumatic spinal cord injury, but in fact, most spinal cord injuries are non-traumatic, and even many traumatic spinal cord injuries, such as something called a central cord injury, where the spine is actually not broken, but there's a contusion of the cord in the setting of degenerative disease. In many countries, isn't even referred to as a spinal cord injury. But certainly, we're recognizing that this is an increasingly important clinical problem. Rob Brownson highlighted this morning in terms of the profound impact of looking at hand and upper extremity function. It's a big deal. And then the chronic lesion. This is what an actual human spinal cord injury looks like. This is a human neuropathology section. I've just listed a few of the issues here. So this isn't just a situation where there's a loss of neurons or disconnection. You actually have a profound gap which forms. This is referred to as myeloablatia. This is typically surrounded by a glial scar, which early on has the benefit of limiting the secondary injury process, but then there are also inhibitory molecules such as chondroitin sulfate proteoglycans expressed in the glial scar. There's clearly loss of cells, there's chronic demyelination. So there are many things that are going on. This is a set of some very nice reviews which were first authored by my colleagues in Vancouver. This is the introduction to this focus issue. The entire issue is freely downloadable in the Journal of Neurotrauma, the August issue, through a grant from the Rick Hansen Foundation. So in Wolf Teslab's article, he stresses a few things, and one is he stresses the absolute importance of cervical models of injury from a translational perspective. And this is frankly a game changer. This has to occur for us to move this forward. The importance of assessing cellular therapies in chronic models, and David alluded to this. Currently we're okay at improving outcome in some models of injury, mainly in the subacute phase, mainly severe and complete injuries in thoracic models. And then clearly, I think we need to look at the combinatorial approaches, whether we actually modify these stem cells or cell-based therapies, or whether we use different types of strategies. This is from a recent review by Crystal and Jared in our lab, and just simplistically, one can maybe categorize the way stem cells might work in terms of potentially sparing tissue, potentially through trophic factor effects and other effects to replace cells and to modify the environment. So one of the strategies that we've pursued is the whole idea of remyelination. Certainly not the only strategy. And this is based on the concept, of course, that myelinated nerve fibers convey many of the important signals in the spinal cord with the nodes of rhombi that fire the action potentials and the oligodendrocytes that make the myelin. And the molecular arrangement of the nodes of rhombi is critical to their proper functioning. After spinal cord injury, in many cases, there is a blunt lesion of the cord. This results in necrosis of the central gray matter and medial white matter. And then in many cases there are residual axons left in the subtial rim, and due to apoptosis of the oligodendrocytes, you lose the myelin, there's incomplete remyelination, and you lose the normal molecular arrangement of these axons. So this is the whole basis for remyelination therapy, and so you need to have enough nerve tissue there for this to work. And so the strategy that Geron had attempted to do prior to stopping the trial, and that Stem Cell Incorporated is working on, is looking at potential remyelination of these residual axons. Of course, neural stem cells might do other things, but this is where perhaps the most compelling evidence has arisen out of the animal models. And so this is great, but this will really only work in humans who have a severe but partial lesion. And you need to have some kind of a readout, either by imaging or electrophysiology, or some kind of an approach to show that you've got enough axons for remyelination to occur. So the strategy that we've used, and Charles talked about all the different types of cellular strategies, has been really to capitalize on the strengths in Canada and Toronto in particular with neural stem cells. And so this, the approach that we've been taken is the idea that if we're going to rebuild the brain and the spinal cord, let's try to use committed adult neural precursor cells. So we take these cells from the subreticular zone of transgenic mice that express green fluorescent protein using a neurosphere assay, and this is just a picture here of a neurosphere. We can then isolate and identify these as clones of neural stem cells, and in the right conditions we can make various types of neural cells. And then to follow up on Rob Brownstone's point is, okay, well that's great, but we're not, it's going to be challenging even with donor pools to try to get these from the brain and the spinal cord. So how can you actually get this from a practical strategy? And so our approach is either to consider using ES cells or induced pluripotent stem cells, and then the idea here that we've been trying to pursue is using something that Derek van der Kooi called the default pathway. And this is the idea that in development, embryonic stem cells by default want to make nerve cells, and what Derek had shown was with LIF and fibroblast growth factor, one can fairly simply make these neural stem cells in culture. And in a recent publication, James Rowland and our lab has validated that in vitro and in vivo models. These are just some pictures from his lab showing that he gets very nice differentiation of various neural cells. And then in more recent work, which has been pioneered in Andras Nagy's lab, Andras has taken the idea of induced pluripotent stem cells, and he's been able to make these iPS cells. So these are primitive cells derived from somatic cells. He's been able to do this without the use of viruses. So I think this has been a huge advance, where he uses an approach called a piggyback transposon reprogramming. And in this way, this is just a cartoon of this. One can take a somatic cell, introduce various critical transcription factors using a piggyback transposon cassette, then remove the cassette so that you have no residual signature of this. And then our approach with Derek has been to take these primitive cells, either in this case iPS cells, using the default pathway, and then we can make adult neural stem cells. And some of the posters that have been next door from the students from our various labs have been just talking about the critical steps related to this. And then we've been using the Shiver mouse as a model just to look at this from a proof of concept. The Shiver mouse is a mutant mouse that lacks myelin-basic protein. And so this is some work from James Rowland just showing the survival of these green fluorescent protein cells in the Shiver cord. And it's been able to get very nice differentiation of various cell types, predominantly oligodendrocytes, as we've been focusing on white matter. This is just some further evidence just showing here remyelination and reconstruction of the nodes of Ranvier as a proof of concept. So we then come back to the issue of the chronic injuries. So this is very nice, but then how do we then try to deal with this? So we've tried to take a step-by-step approach here, and as an initial effort, we've been trying to focus on the glial scar. And so one of the key molecules that James Fawcett and Jerry Silver and others have identified in the glial scar are chondroitin sulfate proteoglycans, and this is just in immunohistochemical stain showing the significant expression of CSPGs. And there's abundant evidence in the literature that these are inhibitory to axonal migration and to the differentiation and migration of stem cells. So this is work from Sohaila Karimi when she was a postdoc in our lab, and this is now in a chronic model of injury. 6 weeks in the rodent is about equivalent to about 6 months to 1 year in a human being. So this is when the glial scar forms. You can see you get a beautiful knockdown of the glial scar using chondroitinase. And now we can see a really beautiful migration, differentiation, and survival of neural stem cells in this kind of a model, whereas we really were not able to do this and nearly as well without the use of chondroitinase. And this just shows beautiful reconstruction of nodes of Ranvier with remyelination. So I'll just walk you through this. This is some behavior. Here we have the BDB scores, which were commented on before, and then we have footfalls. We now have electrophysiology and other kinematics. But we have a number of controls, but the only group here that was able to push the BBB scores up was this combined group with chondroitinase and neural precursor cells. We see here about a 3 to 4 point improvement in the BBB scores. And then we see here, this is a significant reduction in the number of footfall errors on this grid walking device. So it suggested that we're getting significant improvement in the chronic injury models. Another strategy that we've been using from a combinatorial perspective is using nano-engineered approaches, and the idea here to use scaffolds. And from a neurosurgical perspective, this is incredibly appealing